I'm going to continue with showing images of meningioma. And after many years in clinical practice and having scored for several population-based studies in our university hospital, I can confirm that meningiomas are the most common intracranial tumor as cited in literature. Meningiomas do not arise from the brain parenchyma itself, but from the meninges, so they are stuck against the brain like the Play-Doh against the table. Meningiomas have different signal intensity on T2 weighted images depending on the composition and histology, and enhance on post-contrast images. The majority of meningiomas are asymptomatic, and the majority of meningiomas are benign. The most common histopathological subtypes of meningiomas are meningothelial meningiomas made up of uniform tumor cells with collagen septa and calcification. And the second most common meningiomas are fibrous meningiomas made up of spindle-shaped cells forming vesicles with a collagen matrix. There's a relation with radiation, so patients that have had whole brain radiation have a higher risk of meningioma. There's also a risk with neurofibromatosis type 2, and there's probably also a risk with hormones, which might explain the female predominance. Meningiomas can also be atypical with more mitosis, higher cellularity, and sometimes brain invasion or even malignant. To determine if an intracranial mass is a meningioma or not, the question you have to ask yourself is this mass intra-axial, arising from the brain parenchyma, or extra-axial? And this mass is extra-axial. You can see that the brain parenchyma is pushed away, and because there's no edema, this indicates that it's a slow-growing mass, and the most common extra-axial supratentorial mass is a meningioma, and a very common infratentorial extra-axial mass is a meningioma within the differential diagnosis of vestibular schwannoma, if it's in the cerebellopontine angle. To determine if a mass is extra-axial, you can sometimes also identify a CSF cleft, and this meningioma happens to be symptomatic, presenting with a status epilepticus and a lot of edema. And sometimes meningiomas can have a dural tail, which is also helpful in confirming the extra-axial location of the tumor. Meningiomas are named after the location they are derived from. Meningiomas can arise from any location where you have meninges. And meningiomas are derived from arachnoid barrier cells. And in the previous video, we talked about the meningeal layers with the dura against the bone, then the arachnoid barrier cells, arachnoid trabecula below, and then the pia against the brain. And meningiomas are derived from arachnoid barrier cells, not from the trabecula. And you might also remember from the previous videos that the supratentorial meninges are derived from neural crest, whereas the meninges near the skull base and in the posterior fossa are derived from mesoderm. And there's something very interesting if you look at the distribution of the genetic mutations found in meningiomas, because the spatial repartition of the gene mutation reflects the meningeal embryology. The exact relationship hasn't been clarified yet, but there are different subtypes of meningiomas occurring at different locations. And when we look at the most common types of meningiomas, the meningothelial meningiomas occur more often at the skull base, whereas the fibrous meningiomas are found near the convexity. And when you think of gene mutations, I mentioned in the videos on glial tumors the colon carcinoma model from Vogelstein and Kienzler, where you have normal cells and then a low-grade tumor advancing to a high-grade tumor. And they did something like that with meningiomas as well. And this is from an article from 2006. So meningiomas are derived from arachnoid cells. And a very common mutation is the NF2 mutation. So I'm going to discuss that and two additional mutations. And when you look at the NF2 gene, it codes for a protein named Merlin. And Merlin exists in different forms. In the closed form, in the folded form, it links to the actin cytoskeleton, and it acts as a tumor suppressor gene inhibiting the transcription of oncogenes. And this Merlin is also closely related to the Wnt signaling pathway. And Wnt signal is important for the regulation of stem cells and tissue patterning. And I said in one of the previous slides, you have benign meningiomas and you have atypical meningiomas. And it would be nice if we could have imaging markers predicting if a meningioma is benign or atypical. And if you look at diffusion of meningiomas, you can have restricted diffusion, indicative of a higher cellularity. So there's low ADC, restricted diffusion, high cellularity. And these meningiomas had a higher rate of recurrence. And these meningiomas with a low ADC, so the high cellular meningiomas, had activation of their Wnt signaling pathway. So you can use diffusion to predict or to estimate if a meningioma is going to be benign or if it's going to be an atypical meningioma. Then there's another gene mentioned in this scheme that is a cyclin-dependent kinase inhibitor. It's a very well-known tumor suppressor, also described in meningiomas, melanomas, and in IDH wild-type glioblastomas. And in meningiomas, it upgrades the grade of the meningioma to a grade 3. So this is an example of two meningiomas that looked similar at baseline. One in the left middle cranial fossa and the other right sphenoid wing with intraorbital extension. And at baseline, they were both classified on histology as grade 1 meningiomas, but this patient had a CDKN2A mutation. And at the follow-up after 1 year, there was no recurrence in the patient with the meningioma on the left side, but the patient with the right-sided meningioma and the CDKN2A mutation had local recurrence. And in the most recent WHO classification, if you have this mutation, the meningioma gets upgraded to a grade 3. So you can make a distinction between skull base and non-skull base meningiomas. And I said meningiomas can occur anywhere where you have meninges, but there was also an intraventricular meningioma, and that's the odd one out because you don't have meninges intraventricular. So there has to be some embryological remnant that can give rise to intraventricular meningiomas, and we're going to look at intraventricular meningiomas and the embryology of the roof plate in the next video.